Good morning. I guess we should probably get started. Welcome to scientific session number 4. I'm Pat Offner, an elderly trauma surgeon from Denver. Our first paper this morning is entitled Evaluation of Blunt Trauma Injuries and Outcomes with Pre-Hospital Antiplatelet or Anticoagulation Therapy in Ground Level Falls, and will be presented by Dr. Krista Stevenson from the University of Arkansas.
Good morning. Thank you so much for this opportunity. I'm Krista Stevenson. I'm a general surgery resident from the University of Arkansas. And our study is ground level fall. Who do you call? We have no disclosures. Within established trauma systems, trauma centers have established activation criteria to identify patients at risk of significant injury and trauma team activation need. The American College of Surgeons Committee on Trauma has 6 activation criteria that has been coined the Gang of 6 that are criteria in every ACS verified trauma system that all have proven significant morbidity and mortality in trauma. These include hypotension, systolic blood pressure less than or equal to 90, respiratory compromise, central gunshot wound, severe traumatic brain injury, transfusion requirement to maintain vital signs, as well as deemed need by emergency department personnel for trauma team. Additional trauma activation criteria are tailored based on the resources available at the institution and the patient population that serves. However, their majority are based on mechanism or physiologic parameters. In addition to these, many centers have specific activation criteria for specific populations, especially geriatric trauma deemed by age cutoff, or those on anticoagulant or antiplatelet therapy. The trauma activation due to those on anticoagulant or antiplatelet therapy is largely based upon the believed risk of an increased risk of traumatic intracranial hemorrhage or subsequent intracranial hemorrhage progression in these patients. Although this has not been validated in the literature and the true medication's effects remain unknown on traumatic hemorrhage. What some of the previous literature has demonstrated is that traumatic intracranial hemorrhage from a low energy mechanism, such as a ground level fall, is low, with around a 3.5% incidence and even less in those that require intervention. The optimal criteria for trauma activation, especially in these specific patient populations, remains debated and unknown. In August of 2018, in response to TQIP recommendations for geriatric trauma, our trauma activation criteria were altered to include all patients, regardless of mechanism, on a non-aspirin antiplatelet or an anticoagulant, sustaining any supraclavicular injury. This resulted in many trauma activations for low energy mechanisms, such as ground level fall, that would have not otherwise been activated. We believe and hypothesized that these patients only had minor injuries, with a majority discharged from the emergency department without true trauma activation need. So we aim to evaluate injuries and outcomes in the specific patient cohort to ensure appropriate utilization of resources. It was a single center retrospective cohort study at our ACS verified level 1 trauma center that spanned a 3-year period. The inclusion criteria are those that sustained a fall less than 1 meter with any evidence of supraclavicular injury that included abrasions, lacerations, contusions on non-aspirin antiplatelet or anticoagulant use. We included transfers from outside facilities with known injury in order to capture this cohort and evaluate the injuries sustained. We also included those that subsequently deteriorated either en route or immediately upon arrival to the emergency department because of their initial activation based on their clinical stability and activation only due to their anticoagulant or antiplatelet use. We then evaluated injuries, injury patterns, and outcomes. 850 patients presented to our facility that met inclusion criteria with a median age of 75 years and over 75% over the age of 65. 93% had an injury severity score of less than 16 deemed over triage by the Kribari method, and with a low injury rate based solely on ISS, although ISS is not perfect. 48% had no injuries. 42% were discharged from the emergency department. The most frequent serious injuries sustained were intracranial hemorrhages, which were sustained in 16%, so more than previous literature. Extremity fractures that were all isolated in 10%, and vertebral fractures in 5%, although none of these sustained a spinal cord injury or had unstable fractures that required intervention. The interventions performed within 4 hours of arrival to our institution included 6 that required trauma bay intubation. 4 of these had a GCS less than 9 on arrival and had deteriorated en route and would have been activated anyway. 2 subsequently deteriorated in the emergency department. 50% of these had septic etiology and had absolutely no traumatic findings on workup and a negative head CT when you excluded soft tissue abrasions and injuries. 6 required urgent craniotomy or craniectomy, and 1 required an EVD. Of note, none required a thoracotomy or laparotomy and had surgical intervention of an intra-abdominal or intrathoracic injury. ICU for TBI management was 45, and around 5%. However, had a 2-day median stay with many discharged from the ICU and downgraded to the floor within 24 hours. Red blood cell transfusions were given in 4. Blood products were given empirically to correct coagulopathy in 27. Of note, only 59% of these had actual documented coagulopathy after the ROTEM returned. And PCC was given in 3.5%. As far as torso injuries sustained, 5 had multiple rib fractures, 1 had a hemothorax, 1 sustained a blunt aortic injury, and 1 solid organ injury. The hemothorax remained hemodynamically stable and received a chest tube over 1 hour after transfer to drain the hemothorax, never required any additional resuscitation. The blunt aortic injury was a grade 1 injury that was managed non-operatively with aspirin and remained hemodynamically stable. The solid organ injury was a grade 3 renal injury with contrast blush, so it's a grade 2 splenic injury that underwent percutaneous angioembolization over 2 hours after arrival, received no blood products, and remained hemodynamically stable. Our mortality rate was 1.8%, although a significant number of these were due to sepsis or comorbidities, and the other were due to severe TBI. All occurred over 24 hours after admission with a median stay of 5.2 days, and 80% were comfort care status at the time of their passing. There is a price to over triage, although we did not specifically look at cost or charge in this particular cohort. Looking at the previous literature, there is around over $4,000 charge in minimally injured patients for trauma team involvement. However, the main cost comes from taking trauma team personnel away from the OR or other sick patients with the potential for patient harm. Based on this cohort, we conclude that low energy mechanisms such as ground level fall, even with concurrent antiplatelet or anticoagulation therapy, has a low severe injury rate. Although a high suspicion for injury should be maintained, especially traumatic intracranial hemorrhage, trauma team may not be necessary in this cohort due to the low likelihood for need for intervention. Thank you. I'll open the floor for questions.
I neglected to mention, excuse me, that this paper is eligible for the Jack Barney Award and will be discussed by Dr. Bradley Thomas from Carolinas Medical Center.
Thank you. That was well presented, Dr. Stevenson. I'd like to thank the committee for the privilege of the podium. The authors also delivered the manuscript with plenty of time for review, and I thank you for that. The authors conducted a single center retrospective study following revision of their trauma activation guidelines in 2018. The trauma activation criteria were revised based on TQIP recommendations to include trauma team activations on any patient with head trauma on any form of anticoagulation or antiplatelet. The authors sought to answer whether the expanded trauma activation criteria were effectively identifying patients requiring urgent intervention or simply leading to over triage and increased costs. With the 3 years of data that were reviewed, 850 patients were included with a median age of 75. And the included data set, there were at least 60 patients that would have met physiologic criteria for trauma activation due to the initial GCS, hemodynamic instability, or the inability to protect airway. I have 3 questions. Interestingly, of the patients that required ICU admission, the highest percentage of those were on a single antiplatelet agent, and the smallest percentage were on factor Xa inhibitors, despite the fact that the factor Xa inhibitor patients made the largest percentage of patients. What do you think accounts for this? While not addressed in your data set, was there any improvement in the geriatric TQIP data following the expanded activation criteria in 2018? And finally, the 13 patients that required urgent intervention, 6 of those patients required intubation in the ED and would have presumably been an upgrade to a level 1 trauma code. The remaining 7 had 1 EBD and 6 craniotomies. So ultimately, my question is, if the primary outcome of the study is to determine the number of patients that were appropriately triaged based on the revised activation criteria, I'd really like to know how many of the patients requiring urgent intervention would have been missed by the pre-2018 criteria. Thank you.
Thank you. So the first question regarding our anticoagulant versus antiplatelet use and traumatic intracranial hemorrhage, I will start out by saying that this was not our question that we addressed. And so our study was not designed nor powered to address differences in antiplatelet versus anticoagulant, especially DOAC versus factor 10A versus single antiplatelet versus dual antiplatelet on severe traumatic intracranial hemorrhage. The literature in this is very conflicting from what I have read. And I apologize, I didn't give our numbers due to time. As far as our numbers in this cohort, of the 850, around 30% of those were on a single antiplatelet agent, and around 20% of those were on a DOAC or factor 10A inhibitor. However, of those that required admission for traumatic brain injury to the ICU, around 9% of those were on a antiplatelet and only 4% on an anti-10A inhibitor as far as those that were on those medications. So we were not powered to address that. What we find concerning is in the literature that it is conflicting, and in some of the larger studies, especially those on an aspirin or an antiplatelet, there is some concern that there might be increased mortality if you empirically treat those patients with blood products, which is our practice to do currently. So we would like to look at that a little bit more in the future. So if anyone wants to join a multi-center study with that, it'd be interesting to look at. As far as TQIP, so we did not specifically look at it with the cohort. TQIP is difficult because there's a year lag when you get data, and this change was in August of 2018. So we do have around a year of data with TQIP to look at it before and after the change, and we found no change in our TQIP data and our geriatric TQIP data as far as before and after implementation. Your last question, I apologize, I'm trying to remember your last question. Can you repeat it one more time?
Sure. So pre-2018, with the same criteria for the study time period 2018 through 2020, how many patients would have been missed that required an urgent intervention without adding the antiplatelet, anticoagulant criteria for activation?
So of those that were intubated, so we had 6 patients that were intubated. 4 of them had a GCS upon arrival and would have received activation due to their GCS status alone with severe TBI. The other 2 deteriorated a couple hours after being in the emergency department, but less than 4 hours, and would not have been activated or upgraded based on our criteria, and probably would have been intubated by the emergency department staff, and neurosurgery would have been called if a traumatic intracranial hemorrhage was noted. However, they had a deterioration after a significant time after arrival. As far as those that required neurosurgical intervention, none would have met activation criteria upon arrival to the trauma bay. However, with their subsequent decline, there would have been an emergent neurosurgical call, as well as likely a trauma consult call that we would have immediately seen to address these patients. However, they were activated due to their anticoagulant status, and then subsequently found to have the injury that required neurosurgical intervention within 4 hours.
Thank you.
Stewart, San Antonio. Very nice presentation. Relatively simple question. Why did you change your trauma activation criteria? You alluded to TQIP, but that's the trauma medical director and trauma program manager's decision. So why did you change it? And you have nice data. What are you going to do moving forward with respect to that? And I will point out that 16% of those patients had intracranial hemorrhage, it seems like.
Yes.
And that's the whole rationale for is picking up those patients. And it sounds like some of them, well, I'm going to say in many places where there's not a trauma team activation, those patients typically have minimal symptoms, and they may wait a long time for CAT scan without the trauma team being activated. So my second question, a follow on, how, if you're going to modify your protocol, your trauma team activation guidelines, how are you going to pick up that group of patients?
Great questions. Actually, the questions that we've been having amongst ourselves at our institution after this data came out and discussing. As far as the change in our activation criteria, we did it after the pamphlet in 2018 on geriatric trauma with discussion of their intracranial hemorrhage and after reading some of the literature. Due to concern of worsening progression in these patients and need for neurosurgical intervention. And that's why we wanted to look at it in our patients specifically with a low energy mechanism cohort and not including all geriatric trauma that sustained an intracranial hemorrhage. We did revise our trauma activation criteria after discussion. With this data, the discussion that has been proposed is to have a separate protocol when these patients meet the emergency department to not have a trauma team activation, but to have a protocol similar to a stroke team activation in which the emergency department expeditiously gets them to a resuscitation room or a trauma room. They expeditiously get a CT immediately after stabilization or after arrival, and evaluation of this patient does need an upgrade. We had a fairly significant number that did deteriorate before arrival with an initial stability report by EMS. And the other would be that the neurosurgery team would be evaluated when these, or would be notified when these patients came in order for them to be able to expeditiously look at the scan to determine, yes, this is a traumatic intracranial hemorrhage that might need our intervention or not.
Thank you.
We have time for one more? So again, very nicely presented. You said something that kind of struck a little bit of a nerve. Alicia from Phoenix, Arizona. So because I worry that we're trying to go down this road where we don't have to deal with all these geriatric patients and you guys feel like you're overactivated and we want to blame it on money and all these things that I don't believe are true. And what you said that made me stand up was you said, oh, it's like a stroke alert. Well, the stroke alert, the neurocritical and the neurosurgeons they're still notified, just like if we're going to be like a stroke alert for old people, the trauma surgeon still should be notified. The reality is there's only so many people in the hospital 24/7, all right, 24 hours a day. And yes, we have the ER doctors, but they're busy seeing 1,000 ER patients. They can't give that undivided attention to a head injury. So I guess my question to you is, kind of like Dr. Stewart, moving forward, what are you telling us? That yes, we can let the ER do more, let them have a stroke alert, but we're going to call it a fall on antiplatelet alert. And then what? What is your thought process as you create this study and you stand up and present and what you want your children and my children to do moving forward?
So we specifically looked at a very, very narrow patient population with a low energy mechanism cohort. And we wanted to discuss the pros and cons, and we wanted to see what injuries were there in order to further evaluate it. As far as the emergency department and as far as protocols and as far as who is in the institution, I think that's very variable amongst institutions. And I think there's significant variability in ED comfort and in neurosurgery response from institution to institution. And I would never say that what would work for our center would be a blanket statement that would work everywhere. And I would never want to put especially geriatric trauma patients at risk. The concern is when there is a significant number of these that are low energy mechanisms that are being activated and is pulling the trauma surgeon away from an exploratory laparotomy or it's pulling them from someone that's dying on the floor. And there is a significant number. Can we look at this patient if it is an emergency department team that we trust and say, maybe we have time, or maybe this doesn't need to be activated, but it is very institution specific and should be looked at further.
Great. In the interest of time, we should move on. We're running a little bit over time. The next paper to be presented is entitled Proteomic Profiling of Tear Fluid as a Promising Non-Invasive Screening Test for Colon Cancer, to be presented by Dr. Ann Mancino from Central Arkansas Veterans Healthcare System.
Good morning. Thank you, Dr. Offner. And thanks to the Southwestern Surgical for having us here in Hawaii. Although I realize now I probably could have done this virtually from the pool. So Dr. Kaufman could not be here to present, so I will be presenting our research. And my colleagues and I have nothing to declare. Colorectal cancer is often asymptomatic until it reaches advanced stage. For this reason, early detection with screening is important. Screening identifies premalignant polyps which can be removed. Many screening methods are currently utilized, including fecal occult blood, fecal DNA, CT colonography, or endoscopy. The non-invasive tests have some drawbacks in that polyps often do not bleed and are missed on stool tests. In addition, other causes of fecal occult blood excuse me, can lead to false positives. As colonoscopy is required to further investigate positive tests, the demand on endoscopists has increased. A non-invasive test that could avoid the false positives and identify polyps and colon cancer could help triage patients that need colonoscopy and avoid delays in diagnosis. One potential approach is to screen for proteins that are biomarkers of colorectal cancer in body fluids using proteomic analysis. Researchers have identified both serum and stool-based biomarker profiles for colorectal cancer, although none of these have been successfully translated yet into clinical practice. Tear fluid is a biologic mixture that contains relatively high concentrations of proteins and other substances and reflects the physiologic condition of the underlying tissue. Therefore, tear could be a promising source of biomarkers for disease analysis. We hypothesize that protein profiles in tear fluid of patients with colorectal cancer or high-risk polyps are significantly different from those without these lesions. To evaluate our hypothesis, we performed an IRB-approved study evaluating tear fluid from 44 patients undergoing screening colonoscopy. Tear fluids were collected with a syringe after applying sterile saline drops. Colonoscopy was then performed and diagnoses were determined by histological and colonoscopy results. Tear fluids were analyzed using mass spectrometry. Proteins were identified, quantified, and differential expression was calculated. Proteins were considered to be significantly different with a fold change greater than 2 and a p-value less than 0.05. The resulting significant proteins and sample groups were clustered using Ward's method, and the resulting significant proteins were also investigated for protein-protein interaction using the string tool. A gene set enrichment analysis was performed on all detected proteins to identify the top hallmark gene sets that were activated. Final pathology revealed 16 patients with colorectal cancer, 13 patients with tubular adenomas, 6 with hyperplastic polyps, and 9 with no pathology. Subjects were grouped for further analysis into a high-risk lesion group, which was colorectal cancer and polyps, tubular adenomas, and low-risk lesion group, which was normal or hyperplastic polyps. This was done both due to the low numbers in this pilot study and also as this separated the patients that would potentially need colonoscopy if this was a screening tool. A total of 1,512 protein features were detected in our tested tear fluids. A Lima differential abundance analysis revealed that 80 proteins significantly differentiated between high-risk and low-risk groups at a p-value of less than 0.05 and a fold change of greater than 2. This volcano plot shows the log 2-fold change on the x-axis and the negative log 10 p-value on the y-axis. Significantly upregulated proteins are highlighted in red and downregulated proteins in blue. As you can see, 18 were found to be upregulated and 62 were downregulated in the high-risk group versus the low-risk group. All tear fluid samples were grouped based on the 80 significant proteins and are 4 groups. As you can see, normal, hyperplastic, tubular adenoma, and cancer. This heat map reveals a clear separation between the high-risk and low-risk groups. When the string tool was used to investigate protein-protein interactions in the 80 significant proteins, 28 proteins were mapped to known proteins in the string database. The protein-protein interaction network is shown on this slide. Interestingly, there are 3 groups of proteins interacting with each other, and furthermore, there were connections between these groups. The gene set enrichment analysis revealed differentiation of several of the hallmark pathways. These pathways are related to cell proliferation and cell structure, Pathways highlighted in red indicate that the overall pathway is predicted to be upregulated in high-risk samples, when blue indicates downregulation based on the entire protein distribution. 6 of our significant proteins were found to be associated with these top pathways. The up and down regulation of these proteins is marked on this slide. Interestingly, the string protein interaction shows that proteins associated with epithelial mesenchymal transition pathway cluster are connected to proteins here in the middle that are involved in the IL-2 STAT5 signaling pathway. These proteins were also seen to be closely interacting with 3 other proteins, one that was right here, here, and there. And all of these additional proteins, when we looked at our data, were found to be actually having over a 3-fold change. We evaluated the detection rate of these 9 proteins in our tier samples. 2 of the original 6 were detected in all samples, 2 were present in all but 1 sample, and the other 2 were found in 80 and 75% of the samples. For our 3 additional proteins, 2 of them were detected in all samples, and the other was detected in all but 1 sample. By use of proteomic analysis, we have identified several pathways that are either up or down regulated in our high-risk samples and detected non-specific proteins that seem promising for further studies as tier biomarkers. Review of the literature revealed that 9 proteins had been studied in CRC and that these studies correlate with our finding in 7 of these proteins. These 7 proteins seem to have potential as used for biomarkers in a screening test. We would propose using these in a diagnostic panel to provide the appropriate combination of sensitivity and specificity. Our study has limitations. Our cohorts are small, and we were unable to determine differences between polyps and cancers in our studies. In addition, some of the proteins were not detected in all tier samples. We plan to repeat these studies with larger cohorts and improved technologies. In conclusion, our study is the first to investigate tier protein profile in colorectal cancer patients. Although limited, our pilot data demonstrates biomarkers in tier fluids that differentiate between groups of patients with and without pre-malignant or malignant colon lesions. Our findings support the possibility of using proteomic signatures in tier fluid for non-invasive screening for colon polyps and cancer. As stated, we do plan to confirm these findings in a larger cohort. Thank you for your attention, and I'll be glad to answer any questions.
Initial discussion of this intriguing paper will be led by Dr. Alexander Rains from the University of Oklahoma.
Hey, good morning. I appreciate the opportunity to present this. Thanks to Southwestern Surgical, and thanks for getting your manuscript quickly and cordially. Your interesting paper looked at a basic science research with the hypothesis of diagnostic proteomic patterns being found in tear fluid in patients with colon cancer, and that also those protein profiles could be used to differentiate high-risk patients from low-risk patients. And as we know, this is a very important topic. Screening tests are the most effective means for early detection and treatment of cancer, especially colon cancer. The current gold standard is visual inspection with colonoscopy, but we know that there's downsides to that. It's an invasive procedure, perforations, miss small lesions. Other alternatives have been looked at, including capsule endoscopy, stool sampling, CT enterography, serum testing, but each of these have their downfalls with sensitivity and specificity issues and the inability to determine between neoplastic and non-neoplastic lesions. So with your study, you looked at 44 patients who had been scheduled for screening colonoscopy, and they consented for tear sampling and study of those samples. And used mass spectrometry to identify and quantify those proteins in the tear fluid, and identified 16 cancers, 13 tubulovillous polyps, 6 hyperplastic polyps, and 9 normal controls. You labeled high risk as the cancer patients and the tubulovillous lesions, and then the hyperplastic or normal samples identified as low risk. Interestingly, you identified 80 proteins which help differentiate between high risk and low risk lesions, with 62 of those being downregulated proteins and 18 being upregulated proteins. You have to forgive me, I'm not a basic scientist, so I'll ask some questions and maybe they may be simple. My first question is related to the patient experience. So if you could maybe highlight what the actual patient experience was like in obtaining those samples. On the surface, it sounds miserable to me, but maybe I'm just a wimp. Second, with the basic science, I don't know if this is routine basic science or if it requires significant equipment or technology that's not readily available. Is this overtly expensive with current technology, or is this something that could be rolled out on a larger scale easily and cost effectively? And lastly, you identified that there were certain proteins that were not present in all of the samples. And if you could highlight the significance of that, I'd appreciate it.
Thank you very much for your questions, Dr. Raines. As far as the experience of the patients, the majority of the patients did not have much problem with this at all. And there were no infections or any problem from doing this. There are some people who, and I'm a little bit one of them, who do have a lot of trouble with having drops put into their eye. And so there were a couple people who were a little stressed by that. And one person who did not participate because they said they could not put drops in their eye. But the actual aspiration of the tears from the corner of their eye was not really the problem that most people had. Interestingly, the technology that we would probably use in the future for collecting our tears, we now are looking at using a strip, which is called a Shimmer Strip, which is actually a way that people are doing this to look at some other tear proteins in other diseases, where the strip is just placed into the corner of the eye and it irritates it a little and just absorbs the natural tears, and there is no dropping of any saline into their eyes. To sort of go along with your question about the proteins being picked up, we do think that maybe some of them were they were probably there, but they were just at lower levels and not identified. Maybe our sensitivity of our machine at that point was not so good. Also, the Shimmer strips do actually pick up a large quantity more proteins from tears than when you when you drop and actually aspirate tears from some of the research I've looked at. So hopefully we will even get higher concentrations of all these proteins when we're using the Shimmer strips, and that may not be a problem. As far as use of the mass spectrometry, this is something we're using right now for our research, because it is a way we can look at all these proteins and get the information on them. If this became a test that we were going to try to use for patients, although my PhD, who could not come to this, actually says that there are very small machines that they can put right there close to the patients and run things pretty quickly now, would most likely either go to a technology that uses like one of the small cartridges that can run fairly quickly. There is a company that's doing that with some of our colleagues who look at breast cancer and are working on a similar thing to this. Then they're using those cartridges, or even maybe changing and doing some kind of an immunologic test that would also, like an ELISA, or similar ultimately to a pregnancy test, which would be nice. You could just touch the strip to your eye and then it'd say yes or no, maybe in the future. Did I answer all your questions?
You did. Thank you.
Thank you.
Eric Peltz, Kalispell, Montana. That was a great paper. As the technology has advanced for metabolomics, proteomics, the microbiome project, interpretation of this data is very difficult to determine, which ones are bystanders and which ones are actual prognostic markers. I wanted to ask, since this has been applied to a number of different effluents, so you've done tears, there's saliva studies, there's proteomics of stool, there's some studies in urine. What is the best medium? Are these proteins ubiquitous as an effluent from serum that's just getting into secretions? Or could you enhance accuracy with like a combined modality? Because there are studies in stool looking at polyps and colon cancer for proteomics and metabolomics. So would we increase our accuracy of identifying those problematic pathologies to then direct for endoscopy or surgical intervention with a combined modality?
Thank you. Yes, it seems like you could look at different materials to see. I do know that for looking at serum versus looking at the tears, they have found that we're able to cut out a lot of the extra noise that's in serum. Serum does have a lot more proteins that are present. So some of those actually do not make it into the tears because they're smaller fragments and they are filtered out some. So there may be some benefit. I know that there have been some studies looking at some things in stool. And in fact, that's one of the things that they saw an upgrade in stool, the same as we saw an upgrade in tears. I think patient-wise, even though it is a little bothersome to have a strip put in your eye, it's as someone who has had to collect stool for one of those other tests, I think it'd be nicer to really just have a little strip in your eye than have to collect stool. But I agree that that could be something that would be interested in look at it in the future.
Great,
Thank
thank
you.
you.
Thank you.
The next paper to be presented is a paper that's eligible for the best paper by an advanced practice practitioner. It's entitled Veno-Venous Extracorporeal Membrane Oxygenation in the Open Abdomen, to be presented by Lindsay O'Meara from the University of Maryland Medical Center.
Thank you. I would like to thank the Southwestern Surgical Congress for the privilege of the podium. I have no disclosures. Open abdomens have been widely utilized since the 90s, and it is known that patients managed with an open abdomen have an increased risk of morbidity and mortality, including hernias, infection, fistula formation, with some studies reporting mortality as high as 67%. Extracorporeal membrane oxygenation involves draining the blood from the venous circulation, pumping it through an oxygenator where gas exchange occurs, and returning it to either the venous or arterial system. Veno-arterial ECMO is primarily used for hemodynamic support in the setting of decompensated cardiac failure, typically due to pulmonary embolism or cardiac failure, and is associated with significant morbidity and mortality, with a reported survival rate to discharge of only 41%. Veno-venous ECMO is primarily used for respiratory support in the setting of acute respiratory distress syndrome or as a bridge to lung transplant, with most recent cohorts reporting up to a 65% survival rate to discharge. The decision to initiate VV or VA ECMO support is made after a multidisciplinary decision and bedside evaluation by the primary surgical team, an on-call specialty trained trauma surgeon or cardiac surgeon credentialed in ECMO cannulation, and for VV ECMO, the intensivist in our lung resuscitation unit. The inclusion and exclusion criteria for ECMO cannulation at our institution is presented in this slide. Occasionally, surgeons are faced with the challenge of managing patients that require ECMO and an open abdomen in the setting of trauma, intra-abdominal sepsis, abdominal compartment syndrome, and non-trauma related hemorrhage. There remains a great paucity of data regarding the characteristics and outcomes of patients who require ECMO support in conjunction with an open abdomen. Therefore, we aim to describe clinical characteristics, hospital course, and outcomes of patients who required VA or VV ECMO support in the setting of an open abdomen. Patients managed with an open abdomen who required either post-operative VV ECMO, preoperative VV ECMO, or VA ECMO from 2014 to 2019 were retrospectively reviewed from a prospectively collected database at a tertiary care center. Data collected included patient demographics, comorbidities, severity of illness, hospital course, treatments received, ECMO characteristics, and short-term outcomes through hospital discharge. Severity of illness scores consisted of Charlson Comorbidity Index, Sequential Organ Failure Assessment Score, and RESP score. The RESP score was designed to assist in prediction of survival for adult patients undergoing ECMO for respiratory failure. A higher RESP score is associated with a higher likelihood of survival to discharge. 50 patients were identified who received either VA or VV ECMO with an open abdomen. 13 patients underwent VA ECMO with a 23% survival rate. 11 patients VV ECMO prior to their open abdomen with a 55% survival rate, and 26 patients VV ECMO post-open abdomen with a 50% survival rate to discharge. Of the 3 VA ECMO patients who survived, 2 were placed on ECMO secondary to a PE and 1 due to cardiogenic shock. They each underwent an XLAP for hemorrhage control. Of the 10 patients who died, 3 were placed on VA ECMO as part of eCPR. Majority of VA ECMO patients were male, and there was no statistical significance between those who lived and died in regards to severity of illness score. Majority of patients who were placed on VV ECMO prior to their open abdomen had respiratory failure secondary to pneumonia. Majority of survivors underwent a decompressive laparotomy in the setting of abdominal compartment syndrome. Majority of pre-open abdomen VV ECMO patients were female, with no difference in severity of illness scores between those who lived and died. While majority of the pre-ECMO characteristics and laboratory data for VA patients did not differ statistically between survivors and non-survivors, non-survivors presented with a statistically significant higher degree of lactic acidosis at the time of cannulation, which is indicative of more severe organ malperfusion. VV ECMO pre-open abdomen patients also did not differ statistically between those who lived and died in regards to characteristics. However, on a bivariate analysis, non-survivors experienced much higher transfusion requirements, including red blood cells, fresh frozen plasma, and platelets. Majority of patients who required VV ECMO post-open abdomen in both the survivors and non-survivor groups required ECMO secondary to ARDS. Of those who lived, the two most common operative interventions were for abdominal compartment syndrome or trauma. Of those who died, 46% had an exploratory laparotomy for hemorrhage control. Majority of the patients were male. Charlson Comorbidity Index and SOFA scores were similar amongst both groups, while RESP score was worse in those who died. Survivors were likely to be placed on anticoagulation while on ECMO, have longer median days on ECMO support, with longer hospital ICU and lengths of stay. A logistic regression model was used to identify independent predictors of mortality for those who underwent VV ECMO after open abdomen and demonstrated that an increased SOFA score was associated with an increased in-hospital mortality, and a higher RESP score and fewer days on ECMO were associated with an increased likelihood of survival to discharge. Of the 22 survivors in all three groups, 4 were discharged to home, 8 to an acute rehab, 7 to skilled nursing facility, and 3 to a long-term care facility. Limitations to this study include its single center retrospective design without a comparison group and its small sample size. This is one of the first studies to describe patients with an open abdomen in the setting of VV or VA ECMO. While our sample size is small, it does not allow for generalization. Our findings stress the importance of considering the possibility that surgical intervention in the VA ECMO population may be futile. Also, ECMO support is a risk factor for the development of intra-abdominal hypertension, and therefore early recognition and surgical intervention for abdominal compartment syndrome is essential. With advances in techniques such as heparin-bonded circuit tubing, heparin-coated cannulas, and the transition to percutaneous access, we are now seeing an increased use in VV ECMO in the trauma population due to the decreased need for systemic heparin therapy. The presence of an open abdomen alone should not be a contraindication to VV ECMO postoperatively, and patients with severe yet potentially reversible respiratory failure despite an open abdomen should be considered for transfer to an ECMO center for ongoing support. Thank you.
Discussion of this nicely presented paper will be begun by Dr. Eric Peltz from Logan Health.
So that was a great presentation. Thank you. And thank you for the manuscript ahead of time to review. This is a very important paper as we see ECMO applied more frequently. I think some important factors in this, there are some commonalities in your patient population. So these are arguably some of the most critical patients we're going to encounter in our tertiary care facilities. They by nature have organ failure requiring extracorporeal support to maintain life. So VA, venous arterial, for perfusion support of cardiogenic shock, and then VV for respiratory failure. In that setting, another commonality is that their primary medical condition carries an incredible mortality risk. The third commonality is that now we've added all of these patients have had a major surgical intervention. So it makes sense why it's a very small population, 50 patients over 5 years at a busy center. I agree with your conclusion that this small study really is hypothesis generating, and any of the conclusions we make probably need validation. Otherwise, there's a lot of differences in the patients, right? The VA ECMO are cannulated for one reason, VV for another reason. The surgical interventions are for variable reasons. Those introduce some confounding factors. So I'm going to ask 3 questions, but I'm going to group up on the patient populations you presented. So for VA ECMO, you said that your mortality in this group, or survival rather to discharge, was 23%. And compared with the benchmark from the ECMO registry of 40%, maybe this is a futile intervention and we should consider not offering surgery. Can you comment further on whether from your data, we might advise the bedside clinician trying to decide how to apply a surgery, whether you have any other indications? It seems that from your data, if the indication for operation was hemorrhage control, you actually had a 50% survival to discharge. While if the indication for surgery on VA was abdominal compartment, 0% survived. So maybe the indication for the operation would help to guide the clinician on whether surgery would be appropriate. The second group, VV ECMO prior to surgery. So this is again a medical population. Lungs have failed, 80% had pneumonia. They're developing secondary surgical pathology because of their treatment and course. 75% had decompression for abdominal compartment. Your conclusion was that we should consider applying open abdomens and decompression, but I want to have you comment on the patients that died. So of 5 patients in that 11 patient group, 4 of them went to comfort care. So in the manuscript, it very clearly delineates that after open laparotomy, 4 patients went on to comfort care. Not everyone that is in an active process of dying has to do so with an open abdomen. So my question to you is, what role does palliative care play in all of these patients? Are they an intrinsic part of your ECMO team when we're determining, because all of these patients have such a high mortality, they're going to have pitfalls along the way. So we might be able to limit some of that heroic nature of 2 a.m. panic call because the patient has abdominal compartment if those decisions have already been laid out. The third group, now this is one that's probably more familiar to the surgeons in the room. So it's your emergency general surgery patients, your trauma patients. Your group actually had obstetrical hemorrhage, trauma, pancreatitis. We've done our big surgery, and now they're experiencing that late mortality in the ICU, the bimodal distribution that's been well described. Your conclusion was, yes, we should consider applying ECMO, but based on the SOFA score and respiratory score, can you advise us further on who should we limit ECMO in our surgical population? It appears that a low respiratory score and high SOFA score predict mortality. So again, rather than prolong a dying process by adding ECMO, should we as trauma and emergency surgeons maybe consider which patients we would limit ECMO? Okay. So one, VA ECMO, the indication for intervention, does that apply to whether we should do it, or is it a moratorium on all VA ECMO patients don't get abdominal surgery? 2, palliative care for all of them. And then 3, which emergency general surgery or trauma patients might we limit ECMO? Thank you.
Thank you, Dr. Peltz, for your feedback and your questions. For the first question regarding VA ECMO, it is such a small data set that it's difficult to make a conclusion. However, you're absolutely right that the 3 patients that survived were each opened for hemorrhage control. So I think when you look at why the patient was placed on VA ECMO, was it because of a PE or was it because they did terrible in the OR due to cardiogenic shock? If the reason for potentially needing to open their abdomen is hemorrhage control, I think we can have a much more thoughtful discussion with usually the cardiac surgeons, but also it helps to guide how the discussion that we have with the family. So we can say, you know, we've shown that we have a 0% survival rate of patients that are being opened for abdominal compartment syndrome. We may be able to have them survive if they're being opened for hemorrhage control. So not only does it allow us to have a conversation with the primary surgical team as to whether we open their abdomen if they're on this, but also help to guide the discussion that we have with the family. For VV ECMO pre-open abdomen, unfortunately, we do not do a great job of getting palliative care involved in these patients and our critically ill patients. I know that for the VA ECMO patients, so our VA ECMO patients are all managed in the cardiac surgery ICU. Our VV ECMO patients are all managed in a dedicated unit called the lung resuscitation unit. I know that palliative care is now going into the CSICU, but they are not an active part of rounds in the LRU. And you're absolutely right. If we could get them involved early, they could become a part of rounds when it's 2 a.m. and your patient's developed abdominal compartment syndrome and you don't have time to have this conversation about what you know, a year down the road may look like for this, or if they're even going to survive. We could have already started to lay that framework, since we know that developing intra-abdominal hypertension is such a risk of patients on ECMO. And for patients for VV post-open abdomen, obviously you need to look at the patient as a whole, see how how they're doing, what other factors they have. But this is where our multidisciplinary approach to deciding when someone is placed on ECMO comes into play. The RESP score is part of the discussion that they have where it's calculated for the patient. So if the patient has a really low RESP score, they may not be placed on ECMO. And despite the fact that we do a lot of interventions to a lot of people, especially at our institution, we do turn down patients for ECMO all the time. And part of that is a really low RESP score. I do not believe that they look at a SOFA score at the time that they make this decision, but that is definitely something that we could look at or that should be considered. So if you have a patient with a high SOFA score and a low RESP score, you may decide that you don't want to open their abdomen, because you're right, not everyone needs to die with an open abdomen.
In the interest of time, we should probably move on since I've let us get behind. Thank you very much. The next paper to be presented is a virtual presentation entitled "One and Done: Repair of Hernia Recurrence After Prior Myofascial Release," to be presented by Dr. Jeremy Warren from the University of South Carolina School of Medicine.
Good morning. My name is Jeremy Warren from the University of South Carolina. I want to thank you for the opportunity to present our work on redo hernia repair after previous myofascial release. And these are my disclosures. None of these have any relevance to the talk today. So this study was really born out of several years worth of teaching courses to fellow surgeons on open and robotic retromuscular hernia repair and other myofascial releases. And one of the most common questions that we would get doing these courses is, should this be our first hernia repair? And what happens when, someone has a recurrence after these operations? Is this a one and done type of an operation? So really we want to discuss here today the options for repair after previous myofascial release and what our outcomes are for that. There's really been a resurgence of the Reeve-Stopa retromuscular hernia repair in recent years. This is widely considered probably the gold standard, at least for open ventral hernia repair. And with the increase in robotic repairs being done, including retromuscular techniques, this has really taken off in recent years. Just very briefly, this involves incision of the posterior rectus sheath, separation of that posterior sheath away from the rectus abdominis muscle, taking that out to the level of the linea semilunaris. Posterior sheath is closed, which creates a nice extraperitoneal compartment for mesh placement. And then the fascia is closed over the mesh. This is really the basis for the more advanced releases as well, including the transversus abdominis release, which is approached through that retromuscular space, or the external oblique release, which is often done excluding the retromuscular component, but was originally described to also include the retromuscular dissection. The real advantages of this approach is that it does allow a complete abdominal wall reconstruction with minimal tension on the midline closure, and provides a well vascularized extraperitoneal compartment for mesh placement, which heals in very well, resists infection very well. There are several minimally invasive options now as well, including laparoscopic and robotic approaches that have been described. The major disadvantage is wound morbidity with the open repair, though this is somewhat mitigated by the minimally invasive approaches. And the big question that we're addressing today, is this a one and done operation? And so first paper to look at this was from Eric Pauli in the group in Cleveland, and they evaluated 29 patients who had had a previous external oblique release who had a subsequent TAR for repair of their recurrent hernia. They basically described the safety and feasibility of this operation, a fairly comparable SSI rate of 28% for a fairly complex group of patients, and a single recurrence noted. Most recently, and very hot off the press, same group in Cleveland reported 65 patients with a previous TAR who had a redo TAR. Again, a pretty complex group of patients and a pretty favorable SSI rate of 14% and a composite recurrence rate of 22%. And really these studies just show the feasibility of this. And I think this is largely based on a couple of radiographic studies that demonstrate the compensatory hypertrophy of the remaining oblique and rectus musculature after release of either the external oblique or the transversus abdominis release, because neither of these studies have reported any significant bulging laterally or lateral recurrences. And I think that's a really key thing to address, and a key fear that people have of doing a redo myofascial release. Our study looked at our total ventral hernia experience from 2007 to 2020 as contained in either our prospective hernia database before 2013 or in the Abdominal Core Health Quality Collaborative National Registry since 2013. We included all patients with a confirmed prior myofascial release and evaluated them accordingly. We identified 111 patients who had a previous ventral hernia repair with a myofascial release of some type. And you can see that 92 of these patients had a previous retromuscular dissection, either alone or in combination with another myofascial release. Patients who had a previous external oblique repair were approached with an open fashion in all cases. So these 23 patients had a mean hernia width of just under 13 centimeters, so a fairly complex group of patients. And most had a TAR or posterior component separation in addition to their retromuscular dissection, with a single patient having a redo external oblique release. Fascia was closed most of the time. Fairly long operative times, is pretty complex group of patients. Really infection rates comparable to what's reported in the literature, around 20%. And that's really confirmatory of the Paul I article I referenced earlier. For patients with a previous posterior release, this includes both a true posterior release and TAR. Fairly small numbers here, so I won't belabor this, but essentially, fairly longer operative time for redo retromuscular repairs, all of which were done in an open fashion, but fairly good results. Again, these are pretty small numbers, so I think it's hard to draw a lot of conclusions from that, but it is consistent with the Monteleone findings of the second article I referenced previously. And then really the meat of our article here, we had 32 patients with a previous retromuscular repair that had a redo retromuscular repair, and 38 patients who had a laparoscopic or an open IPOM repair. A little bit larger hernias in the redo retromuscular group, longer operative time as to be expected, and that was a statistically significant difference. But there were no other statistically significant differences in outcomes. Length of stay, infection rate, surgical site occurrences, other general complications, and recurrence rates were all similar between these two groups. The follow-up is longer for the IPOM repair, so I think that is a potential source of bias for the recurrence rate. So really the retromuscular repair is not a one and done operation. It is possible to do an external oblique release after a previous TAR, a TAR after a previous external oblique release, or even redo any of those releases as needed. Redo retromuscular repair is more complex operation. To be sure, it is a more difficult operation, but it is feasible, and the outcomes are still pretty good based on our study and the others mentioned previously. I think the laparoscopic IPOM is still a very suitable repair option, particularly for smaller hernia recurrences. And really just to sum this up, the decision making on how to proceed with a recurrence after one of these complex hernia repairs certainly depends a lot on surgeon experience, but in our hands, larger defects, probably around 8 centimeters, are rarely repaired with an IPOM approach. I think we just don't get as good of a repair of the abdominal wall, and it requires a very large intraperitoneal mesh. Younger patients with a higher potential long-term risk of an intraperitoneal mesh are also less likely to get a lap IPOM repair, and usually we'll have an open extraperitoneal repair of some kind. And really our end goal is a restoration of the function of the abdominal wall for good long-term outcomes. I'll stop there and be happy to take any questions. Thank you for your time.
Discussion of this paper will be begun by Dr. David Mercer from the University of Nebraska.
Thank you. I'd like to congratulate the authors on an excellent presentation and for getting me the manuscript well in advance, so I didn't have to read it on the plane. I would also point out that the title of this manuscript, One and Done, just happens to be the name of my new putter. And after playing yesterday, I'll just tell you, that ain't true. So this is an interesting paper by a group of surgeons known for their high volume and complex abdominal wall reconstructions. Furthermore, they are operating on high-risk patients, high BMI, COPD, type 2 diabetes, that by definition will result in a higher recurrence rate in patients that have already recurred at least once. Also, some of these surgeons were at the forefront of these techniques, i.e. external oblique release and robotic retromuscular repair. So my first question of 5 is whether your recurrences occurred in patients earlier in your learning curve, as I suspect they did. Secondly, in the conclusions, you state that the retromuscular space can be accessed for subsequent repair and that prior myofascial release does not preclude subsequent release using an alternative approach. In their hands, I can see how they were able to go back and into the retrorectus plane or go intra-abdominally and do an intraperitoneal onlay repair. However, I suspect the average hernia surgeon may have some trouble doing so. So secondly, do you recommend this for all hernia surgeons operating in this space? My third question is, how did you decide to go laparoscopic versus open versus robotic? Fourthly, why the differences in follow-up between the retromuscular repairs versus the intraperitoneal onlay repairs, 8.2 months versus 32.7 months? And then lastly, do the authors believe retromuscular replacement of mesh is a true muscle release alone without external oblique release, posterior, anterior? Many in the American College of Surgeons don't seem to agree, and there is controversy in the billing as a result. Once again, I'd like to congratulate the authors on a fine manuscript and the opportunity to discuss their paper.
All right. Very good. Dr. Mercer, thank you so much for those questions, and thank you everyone for your time. So I'll try to hit these pretty quickly. So as far as our recurrences, whether they were early or late, we did not track that clearly for this paper, mostly due to a relatively smaller overall study. So we were not looking at exactly when these hernias recurred. Just in some of our other work, these tend to recur within 1 to 2 years. We've never identified a clear association with learning curve, though that is certainly a possibility and something that we should look at in the future. As far as the technique of this and reaccessing the retromuscular space, no question is difficult, but it's not necessarily more difficult than a lot of the other spaces that we re-enter as general surgeons. A reoperative abdominal cavity can be quite difficult as well. And in many cases, this is less worrisome because you don't actually have to worry about the bowel, and really the underlying intra-abdominal adhesiolysis is sometimes even more daunting than this. It is a tedious dissection. You do have to be more careful. You're far more likely to get bleeding and get into the epigastrics, and you have to be aware of that. But it is possible. Is it for all surgeons? Probably not. I think if your volume is pretty low, this is not a great option for you to charge into. But if you have adequate volume, you have the right practice, the right training to do retromuscular repairs, I think it does lend credence to doing this as still a good index hernia repair, or at least the first time retromuscular repair, because if it does recur, you still have that option to send it to another referral center who is more comfortable with doing these redo repairs. Our decision making for lap versus open versus robotic is largely based on size and complexity of the recurrence, but a lot of it has to do with the patient's skin condition, skin quality, and a lot of their expectations, their lifestyle, what kind of shape they're in. So, a 45-year-old male who's still, going to be working at a, moderately physical job with a 10-centimeter recurrent hernia is probably going to get an open, maybe robotic redo retromuscular repair. Poor skin quality, big dystrophic scars, but much more likely to be an open repair. I think for small hernias, and particularly these we see sort of at the upper or lower extremes of the midline that are 3, 4, 5 centimeter hernia, particularly in an older patient that's less active, I think a laparoscopic IPOM repair is a fantastic repair for those. Our difference in follow-up, I think, is primarily related to the overall change in our practice. We do a lot less straight laparoscopy now than we used to. And I think that's the primary driver of the difference in follow-up, as well as just some general changes in how we're able to bring patients back in. We used to no charge all the patients to come in for long-term follow-up when we're not allowed to do that anymore. So that kind of sways us in bringing patients back in to not have a unnecessary bill. And then finally, is the retromuscular release alone a myofascial release? I would say an emphatic yes. And even if you look back to the original Ramirez paper, the mobilization of the abdominal wall toward the midline just with the retromuscular dissection is still around 5 centimeters of the total 10 that he gets with a complete anterior component separation. And that's been borne out by a few other studies. Nowitzki's done a few of these looking at a very stepwise myofascial release of what happens when you release the posterior sheath, when you release the posterior lamina of the internal oblique, when you divide the transversus abdominis, and each one of these provides some additional release along the way. So yes, it has been a billing issue. In our opinion, it is emphatically a myofascial release. There may be some changes coming out, looking at alternative ways to build this from myofascial release versus an adjacent tissue transfer. Stay tuned. But in my opinion, yes, it is absolutely a myofascial release.
Thanks for the responses.
Of course. Thank you.
Thank you. The final presentation for this session is also a Jack Barney Award eligible paper entitled The Big Picture Struggles, Appropriate Imaging for Geriatric Populations, presented by Dr. Christopher Piercy from Methodist Dallas Medical Center.
Thank you for the introduction, and I appreciate the privilege of the podium. Here to present our work at Methodist today, as you said, we have no disclosures. The trauma population we know is aging. This population is complicated by multiple comorbid conditions, polypharmacy. There's a higher tendency or higher frailty scores among these people and different mechanisms of injury compared to their younger counterparts. At Methodist, we established a G60 trauma program, which includes all patients over the age of 60 years old with an acute injury who don't meet higher level activation criteria. They're evaluated by our trauma team within 30 minutes of presentation. And the program focuses on a multidisciplinary approach with internal medicine for co-management of comorbid conditions and preoperative optimization, pharmacy involvement for accurate medication reconciliations, as well as early identification of anticoagulant or antiplatelet use. Orthopedics and neurosurgery teams always involved early when appropriate, with a focus on early operative intervention within 24 hours usually. And the goal of the program is to promote return to pre-hospital functional status or as close to that as possible. Among our physicians at Methodist, we noted there was a difference in imaging strategies. We have those that are what we call pan-CT scanners, who image everything, head, C-spine, chest, abdomen, pelvis, on any of these G60 patients that come in. They promote that it's early identification of injuries, likely a lower missed injury rate, which in a more frail population should result in better outcomes. We also have selective CT scanners who, based on the history and physical exam, signs of external trauma, as well as the mechanism of injury, whether or not they need to image particular body parts. So a selective CT scanner is considered anyone who does anything short of the pan-CT scan. And we wanted to know, is there any outcome advantage or disadvantage between these two strategies? Imaging in the trauma patient, the CT scan is the modality of choice, and there is some literature on this already, and the results are somewhat mixed. There are some older studies that showed a slight mortality benefit in pan-CT scanning patients, and there's some more recent data in the level 1 and pediatric populations that show no difference in overall outcomes. Now, there's an associated increased cost and risk of radiation exposure with multiple imaging studies as well. So our hypothesis was in geriatric trauma patients who underwent selective CT scans versus pan-CT scans would have similar outcomes without an increase in the missed injury rate. It was a retrospective registry review from our trauma population, all G60 activations from June 2016 to June 2019. We excluded patients who did not have complete imaging results. Most of those were transfers from outside facilities or in patients with traumatic injury who didn't meet the G60 activation criteria. These are the statistic models that we use to analyze our data set. Looking overall, about 61% of our patients got a selective CT scan, which was higher than I thought it would be. When you break it down by mechanism of injury, patients who came in as falls from standing, 2/3 of those got selectively CT versus only 1/3 in the pan CT cohort, which still seems a little high to me. In the patients in MVCs, about 80% of those underwent a pan CT scan, and assault victims, 58% versus 42% in favor of pan CT. And of note, about 99.8% of these were blunt injuries, most of them being falls from standing. Looking at the demographics between the two groups, the only significant difference was the age, slightly higher in the selectively CT scan population. Gender, admission, GCS, ISS, and head injury AIS were not significantly different between the two. And then after adjusting these for age, gender, injury type, severity, as well as GCS, the only thing that we found a difference in between the two groups was the ER length of stay, which doesn't come out to much, but it is statistically significant. The hospital length of stay, ICU vent days, likelihood to discharge home, and mortality were the same between the two groups. We looked at a subset population. There's some literature, and at least anecdotally, that the patients on anticoagulants, as well as those with a past medical history of dementia or major psychiatric illness, are more likely to be overimaged. We didn't see a difference in the imaging strategy in these patients. We looked as well at the rate of missed injuries, or not the rate of missed injuries, the rate of injury detection in this cohort as well. And we found that of patients who underwent only selective CT scanning, they found a head injury in about 1/3 of those patients, whereas patients who are pan CT scanned, they were only found to have a head injury in 17% of those, and that was statistically significant, implying that our clinical judgment rather than the pan CT scan is accurate in screening for and diagnosing these problems. We looked at missed injury rate, which was low overall and not statistically significant between the two groups, 0.2%, 0.3%. The study definitely has limitations as retrospective, single institution, and it doesn't account for individual practitioner practices. These get lumped all together in our data set, but some selective CT scanners also pan scan patients when they feel that's appropriate. So it might provide a little more insight to delineate that further. And then we investigated or included a limited number of comorbidities in the data set as well. So overall, we think that the outcomes and missed injury rates in our G60 population were not statistically different between the pan and selective CT imaging strategies. Practitioners were able to identify those high-risk groups for head injury, the ones on anticoagulation or with past medical history of dementia or psychiatric illness. There is still a role for history and physical exam to guide the imaging workup in this population, and further research is needed to provide validated practice guidelines. That's all I have. Thank you again.
Discussion will be led by Dr. Elizabeth Sher from UT Health San Antonio.
Hi there. Thanks for having me. Thanks to the team for providing the manuscript well in advance so I could take a look at it. It's a well-done retrospective analysis of imaging practices for an important patient population that, as you point out, is increasing in number. I applaud your efforts to try to examine patient patterns or practice patterns that can help us ensure we provide appropriate, efficient, and cost-effective care for our patients. I have a few comments and a couple questions that I hope you can help clarify. At your institution, what criteria do you use to determine what a level 3 trauma patient is? The mechanism of injury is predominantly ground level falls for these patients meeting your level 3 criteria. However, some of the outcomes you report are ICU length of stay and days on a ventilator. What proportion of your level 3 patients went on to go to the ICU or need the ventilator? Is it possible that these patients were under triaged? And do you think that might have an effect on your data? I too found it interesting that selective CT was used more frequently for patients with a history of anticoagulation, dementia, and psychiatric illness. As you mentioned, this is counterintuitive. These patients have higher risk of bleeding and decreased ability to provide a reliable history and physical exam, which you point out is something that we should rely upon more than pan CT scans. Furthermore, patients who had selective CT scanning were older. How do you explain these findings? Table 1 shows that the mechanism plays a role in this decision-making about imaging. Do you think that these data are applicable to institutions that do not have the G60 program that helps you guide these questions and identify higher risk patients? Is obtaining this type of information about mechanism of injury what you mean by using physical and history to be able to guide your imaging choices? And do you think an algorithm could be created for programs without the formal G60 programs in place? Thank you so much.
Thank you for all your questions and the opportunity to discuss the paper. At Methodist, our G60 activations are technically separate from a level 3 trauma activation, but it's basically just anyone over the age of 60 who doesn't meet the other criteria. This can include in our population, and I think probably accounts for the majority of the ICU and ventilated patients, are some patients who come in, if you're over 50 years old with multiple rib fractures, 3 or greater, then you go to our ICU for at least a 24-hour period. I think that probably explains a portion of those patients. And I also don't know how well captured patients who get early operative intervention for orthopedic or neurosurgery procedures and wind up back in the ICU post-operatively intubated may account for some of the ventilator days as well. I don't think that that necessarily represents under triage. We also have, I mean, that's kind of our standard at Methodist. We also have some patients who come in and they may have like a minor or a small subarachnoid GCS of 15, and then that becomes kind of neurosurgeon dependent on whether those go to the ICU or not. I think the next question about selective CT scanning and the anticoagulated and kind of altered mental status group, I do think that that imaging selection is probably mechanism based, because still a lot of these are maybe a fall from standing, no external signs of trauma, and individual practitioners may not feel that a full body CT scan is warranted in that patient despite their inability to provide a complete history. So I do think that's probably mechanism driven. I think that it's applicable to programs that don't have a G60 program. I think that now it's been shown in a few studies among pediatric populations, among severely injured level 1 trauma populations, now in some geriatric trauma populations. And I think as you get more and more data, I think it is generalizable. And I agree with you that I think the 24-minute increased length of stay in the emergency room is not clinically relevant. We did look at missed injury rate by going back and chart reviewing and basically finding any injuries beyond the initial trauma evaluation that identified injuries, and the overall rate was low. In our registry, it's kind of difficult to collect. It doesn't show 30-day readmission rates, but it's something that we can fairly easily go back and identify, and something that we can do in the future. And then also return to baseline functional status. We had likelihood to discharge home, but not necessarily long-term follow-up on any of these patients. And that's something as well that we are currently looking at in another study going forward.
Great job. Thank you.
Despite being overtime, it's hard not to let Dr. Mangrum comment on this paper.
And I'll try to be super quick. I really want to applaud you, and I want to applaud your program director for continuing to look at our geriatric trauma population, because it's going to continue to increase, at least what the data and all the smart people tell me, till about 2050. So we do have to try to figure this out, okay? But while we're trying to figure out what to do with them, do we think, and I guess this is my question, what year are you? Fourth year. Okay. Do we think that the 4th year resident or the brand new ER attending or the 70-year-old doctor who hasn't retired yet can make these individual decisions on, oh, he's not too sick. Let's just scan his head. I don't think he hurt his neck. We don't need to do this. And I mean, we have people that have taught us so strongly. Ernie Dunn, who was a previous president of this organization, he did a study back in, I don't know, 1999, and said, is it worth doing a CT of the head and neck and just throwing on the chest, abdomen, and pelvis for the heck of it? And he found 30% missed injuries when we didn't do that. So we keep going back and say, well, maybe we don't need to do this. And we keep going back and we're gonna hurt some people over a 5-minute CT. Right? It's like going back and going to a cell phone. You want to go to a payphone and drop a quarter? When we have this, we have a cell phone, we have a CT. It takes 10 minutes to go. Roop, roop. So I just caution us. I'm worried about you young people. Scan me all the way. I don't know what I did. Okay.
We'll
right.
pan scan you if you come
Pan
through our
scan.
trauma bay. Yeah, no, it's a good question. And this actually, you know, going forward is I think the most difficult thing to deal with, is because you and our practitioners at Methodist Dallas, who are ultimately in charge of making those decisions, the ones who pan CT scan everybody, say to us exactly what you say. And then anecdotally, we feel sometimes as residents that we pan CT scan all these people that tipped over in a wheelchair or fell from 2 feet, and it, you know, it takes not a significant amount of time, but is like my, you know, I think my clinical judgment in evaluating these people as a 4th year is probably adequate in diagnosing most of these injuries and low energy mechanisms. But we CT scan all kinds of people, it feels like, and they're all negative. They all come back negative. And we looked through in our data set, at least the few missed injuries that we were able to identify. And even those, none of those on either side actually resulted in any clinical intervention. They were minor injuries diagnosed on something else down the road. So I think I understand the question. I don't have probably a great answer for you, because I think it's practitioner dependent, and even with our project, it's a little difficult to change the minds of the people within our own institution. So we'll keep working at it, but certainly we'll pan CT scan you if you come through.
Thank you. This ends the session, and the expert panel is next.